Chapter 13 covers first aid and initial injury care. Earlier in the semester, we defined two types of emergencies that require first aid: a sudden illness and an injury. A sudden illness is a physical condition that requires immediate medical attention, such as an allergic reaction, heart attack, or stroke. Injuries are defined as damage to tissues that occur from outside forces. Emergencies are either life-threatening or non-life-threatening. A life-threatening emergency impairs the ability to circulate oxygenated blood to all parts of the body. A non-life-threatening emergency does not prevent the circulation of oxygenated blood, but still requires medical attention. Basic first aid is the care provided to someone who has sustained an injury or has developed a sudden illness until more advanced care can be obtained. Athletic training students just beginning in an athletic training education program should be trained in first aid. As students advance and receive more training, they can take on the role of first responder. First responders are people who, due to the nature of their jobs, may find themselves caring for emergencies often. They are on the scene and have the supplies and equipment available to provide first aid care on a regular basis. They are the transition between the basic first aid a trained citizen may provide and the advanced care emergency medical technicians are trained to provide. Many athletic trainers who work in environments where acute care is common pursue additional emergency medical technician training, although it is not required for certification by the BOC. In an athletic training environment, first aid is sometimes thought of as initial care. Initial care is the care that is provided to an injured person immediately after the injury occurs. Initial care is an important first step in the overall treatment and rehabilitation of an injury. Reducing pain, controlling swelling, and protecting the tissues are the initial care goals. Athletic trainers are often called upon to provide care to skin injuries for athletic populations. As the largest organ in the body, the skin is made up of two layers, the epidermis and the dermis. When trauma to the skin causes a disruption or break in the continuity of the tissue, it is called a wound. There are a variety of open wounds that include damage to the outer layer of skin. The forces that cause the injury or the resulting arrangement of the tissue once it has been injured determine how an open wound is classified. An abrasion is a common wound that results when the skin is scraped. Mats, rugs, court surfaces, asphalt, artificial turf, and equipment are common rough surfaces that can cause an abrasion. The abrasion can be problematic due to the top layer of skin being scraped, exposing capillary beds. These beds are susceptible to dirt, debris, and bacterial agents that may cause a subsequent infection. An abrasion tends to ooze rather than bleed like other wounds. Like all wounds, the abrasion should be cleaned of debris, treated, and covered following standard precautions. Blisters are caused by repetitive friction. Rubbing of the skin causes the formation of fluid between layers of the skin. The athletic trainer must decide whether to drain the fluid from the blister or leave it to its own course, which can be based on the athlete's comfort and location of the blister. Most often, the blister will be drained using sterile techniques followed by cleaned and covering of the area. A laceration is a wound that results in irregular edges to the skin once it has been damaged. Lacerations occur when the tissues are torn by a sharp object or when direct pressure to the tissue causes it to break. Equipment edges or items in the field of play may cause a laceration. A common mechanism is an elbow to the eyebrow while rebounding a basketball. The pressure of the blow causes a jagged, lacerated wound. Lacerations, like any open wound, must be cleaned of debris, treated, and covered following standard precautions. Lacerations tend to bleed immediately and may cause damage to the underlying tissue as well. Direct pressure to stop bleeding, proper cleaning, and closure are appropriate initial treatments. Butterfly strips, steri-strips, and wound closure strips are common dressings for lacerations. As these wounds frequently occur in the facial region, it is important to be sensitive to the patient's appearance and refer him or her to a physician to determine the need for sutures. Incisions are wounds that result in very smooth edges. They occur when a sharp and smooth object causes damage to the skin and possibly anatomical structures nearby. The most common incisions are for which an athletic trainer cares are those that occur in patients who have had surgery. However, sharp edges of equipment, glass, and metal may cause wounds that have smooth edges. Incisions tend to bleed and must be referred to a physician for evaluation. As always, standard precautions should be adhered to when dealing with all open wounds. In caring for open wounds, it is important that they be covered to help control bleeding and to prevent infection. This is accomplished by using dressing and bandages. Dressings are pads placed directly on a wound to absorb blood and other fluids to protect from infection. most dressings allowed for some air circulation to promote healing, such as sterile gauze and non-stick dressing. If a wound needs to be protected from air, an airtight dressing, called an occlusive dressing, can be used. Bandages are any material that is used to wrap or cover a body part. Bandages hold dressing in place, apply pressure to control bleeding, protect the wound from dirt and debris, and provide support to an injured limb. Sterile technique ensures that dressings are sterile and that the area that covered the wound is not touched. This is done by holding only the corners of the gauze while cleaning a wound, never touching an ointment or an antiseptic tube to the surface of the dressing, always opening dressings by the corner of the package to minimize exposure, and always using standard precautions. A minor wound can be treated using the following steps while adhering to sterile techniques. Use disposable gloves worn appropriate barrier between your hands and the wound. Apply direct pressure to the wound using sterile gauze. Irrigate the wound with a sterile water solution for several minutes. Clean the area around the wound with mild antibacterial soap and water. Cover the wound with sterile dressing and a bandage, and dressings should be inspected and changed often. Details of each of these steps can be found on page 288. The microorganism Clostridium tetani can cause tetanus when it infects wounds. This organism can multiply in an environment that is low in oxygen, which makes puncture wounds and deep wounds at a particular risk for infection. The organism produces a powerful toxin that can affect the central nervous system. Tetanus is sometimes called lockjaw due to the spasm that can occur in the muscles around the jaw. Once in the nervous system, the effects are irreversible. Thorough cleaning of all wounds is an essential first line of defense for prevention of tetanus, as well as other potential contaminants. Tetanus vaccines and boosters once every 10 years can help reduce the risk of CNS involvement. However, if a patient does have a puncture wound, a booster is recommended as part of the immediate course of treatment to reduce the risk of a tetanus infection. A major wound is one that has severe bleeding, an embedded object, or deep destruction of tissues. Steps for caring for such wounds include the following. Activate the EAP, put on disposable gloves, control bleeding in a similar fashion to treating a minor wound with applying more pressure and dressing if blood soaks through them, monitor airway and breathing for the patient while awaiting arrival of EMS, position the patient to minimize shock, keep the patient from getting chilled or overheated, reassure the patient and continue to monitor his or her vital signs, and remove blood-soaked gloves and clothing with care and dispose of properly. Further details of these procedures can be found on page 289. Shock occurs when the circulatory system can no longer circulate oxygenated blood to all parts of the body. This is caused by a shift in a fluid volume due to the dilation of blood vessels and the disruption of osmotic balance. During shock, the plasma moves from the vessel into surrounding tissue, causing circulation to slow. When oxygenated blood is not readily available, vital systems are compromised. If left untreated, shock can be fatal. Shock can be associated with severe injury. There are 7 types of shock: anaphylactic, cardiogenic, hypovolemic, neurogenic, psychogenic, respiratory, and septic. Anaphylactic shock is a life-threatening allergic reaction to a substance. Cardiogenic shock results from the failure of the heart to effectively circulate oxygenated blood to all parts of the body. Hypovolemic shock occurs from severe bleeding and the loss of blood or plasma. Neurogenic shock is a disruption of the autonomic nervous system resulting in blood vessels expanding and causing a rapid drop in blood pressure. Psychogenic shock is like neurogenic shock in that the emotional circumstances cause a rapid drop in blood pressure due to temporary dilation of vessels, reducing the normal amount of blood available to the brain. Respiratory shock occurs when the lungs cannot supply enough oxygen to the blood. Septic shock is dilation of the blood vessels caused by severe infection, typically bacterial. For more details on each type of shock, please see the table on page 289. While the cause of shock may not be readily evident, it is essential that the athletic trainer recognize the signs and symptoms of shock, which include the following: pale or ashen blue, cold or moist skin, rapid breathing, rapid and weak pulse, excessive thirst, nausea or vomiting, restlessness and irritability, and altered consciousness. The treatment of shock will depend upon the cause. If there is any question, always activate the EAP. In the event of shock, monitor the patient's airway and breathing, maintain body temperature, elevate legs in certain circumstances, nothing by mouth or NPO, keep the patient calm, and control bystanders. While complete understanding of the chemical reactions and hormone-mediated events in the healing process is beyond the scope of this text, it is essential to know some of the key components to guide proper first aid and initial care of injuries. Injured tissue responds with a predictable chain of physiologic events. The inflammatory process is a complex sequence of mechanical and chemical events that cause tissues to respond in a specific way. Alleviating some of the discomforts of the inflammatory process is the primary goal for most early treatment interventions following injury. The healing process is divided into 3 distinct phases: inflammation, repair, and remodeling. Key physiologic change and specific events are associated with each phase. The first phase is the inflammation phase. Tissue injury causes a physical disruption of cellular structures, leading to a host of chemically mediated activities at the cellular level. During the inflammation phase, many of these chemically mediated processes overlap and occur simultaneously. These include the following: release of a chemical mediator, increased capillary permeability, which cause pain, leukocytes cleaning up damaged tissue, swelling begins to develop, which leads to the inhibition of movement and increased pain, and clotting factors set in to wall off in the injured area and prevent blood loss in the area of the injury. Unless aggravated by additional injury, this phase can last up to 5 days. There are 5 cardinal signs of inflammation: pain, heat, swelling, redness, and loss of function. Details of how each of these play a role in the inflammation phase can be found on page 291. The second phase is the repair phase. As an injury moves from one phase of healing to the next, there is some overlap between phases. During the inflammation phase, large white blood cells, called macrophages, help rid the injured area of debris and help neutralize the chemicals causing changes to the tissue and sensitivity to pain. Once this is accomplished, the repair phase of healing takes place. During the repair phase, the development of new tissue through the production of collagen and elastin and new capillary formation is seen. The new tissue is fragile and easily disrupted, making re-injury a concern during this phase. Key elements to the repair phase of healing include the following: fibroblasts form, and as they increase, a decrease in macrophages occurs. Capillary buds begin to form in endothelial cells, formation of granulation tissue occurs, and fibroblast cells produce a matrix of collagen and elastin, which are distributed haphazardly that creates a fragile scar. Unless re-injury occurs, this phase can last up to 21 days. Common therapeutic interventions during the repair phase include ensuring that active inflammation is controlled, as therapeutic choices may progress to the use of heat modalities. The cautious use of controlled and protected motion and functional movements are often during this phase, as protecting fragile tissue is of importance. The third and final phase of the healing process is the remodeling phase. New and fragile collagen and elastin form a matrix of scar tissue. The formation of scar tissue is known as fibroplasia. This fragile tissue will begin to change and become stronger and more organized. During this phase, collagen fibers transition as some of the types of collagen are broken down, and while new, stronger tissue takes its place. Identifiers of the remodeling phase of healing include the following: realignment and remodeling of tissue, increased organization and strength of new tissue, and scar contraction takes place as new tissue is laid down and organized. Several therapeutic interventions are designed to help this tissue align and become organized based on the stresses placed on it. Functional movements, range of motion exercises, and gradual weight bearing are just some of the examples of the influence of therapeutic exercise on this process. The prospective athletic training student should have a basic understanding of the principles of immediate care of athletic injuries. The initial care following an injury is designed to combat swelling. Swelling is the common denominator for most acute injuries. Bleeding, synovial fluid, and the byproducts of inflammation can all cause swelling. Swelling can cause limitations in motion, inhibit the healing of tissues, and the increased pressure stimulates pain receptors. The PRICE concept is essential in the fight against swelling. PRICE stands for protection, rest, ice, compression, and elevation. Protection can come in several forms. Appropriate splints, braces, slings, or immobilization devices should be used to protect the body part from further injury. Crutches may be used for ambulation to avoid the stress of weight bearing. Rest applies to the injured body part. Athletic trainers will employ the concept of active rest. Active rest allows for the rest of the injured body part while continuing to work other body parts and maintain cardiovascular fitness. The use of ICE for acute injuries is widely supported. It is primarily used to provide pain relief, decrease the metabolic activity at the injured site, and promote local vasoconstriction. Studies suggest that ICE alone has a greater impact on pain relief than swelling. Compression can have tremendous impact on decreased swelling. The purpose of compression is to reduce the space available for swelling by applying pressure to the injured area. This can be accomplished with elastic wraps, foam pads, and specific therapeutic devices. Gravity will cause edema to pool in the extremities. To combat swelling following an injury, the extremities should be elevated to assist with lymphatic drainage and venous blood flow. Gentle muscle contraction can also assist with venous return. The extremity should be elevated well above the level of the heart. The use of splints is likely one of the oldest injury interventions on record. Tree limbs and branches have been used for centuries to temporarily support injuries to bone. While modern materials have allowed us to eliminate such primitive techniques, the principle remains the same: provide rigid support above and below an injured bone. A variety of splints are available to athletic trainers. Rigid, padded, flexible, and vacuum splints are common pieces of emergency equipment that should readily be available for the athletic trainer who may encounter acute bone trauma. Padded and rigid splints made of foam or cardboard are commonly used for upper and lower extremity fractures. Additionally, there are several types of rigid splints, such as a SAM splint, that can be bent to better conform to the shape of the affected extremity. A summary of basic principles of splinting are as follows. Splint only if you have to move an injured person and can do so without causing further injury. Splint the injury in the position you find it. Splint the joints above and below the injury for proper stabilization. Always check proper circulation before and after applying a splint. If possible, remove any clothing that may impede the splint from working properly. And if there are any open wounds or exposed bone, bandage appropriately. For more details on basic principles of splinting and further specific guidelines, please see pages 296 and 297 in the textbook. In several instances, athletes may need to use crutches to assist with ambulation. The athletic trainer must be able to provide a proper fit and instruct the patient on crutch use. Crutches are commonly used for non-weight bearing, partial weight bearing, and gait training for patients with lower extremity injuries. It is imperative that crutches are fit properly to allow for safe and effective use. The following guidelines should be followed to ensure proper fit and are also shown in figures 13-4. The athlete should wear non-slip shoes. Their shoulders should be relaxed and level with the head held up in an upright position. Crutch tips 6-inch lateral and 2 inches anterior from the anterior lateral aspect of the shoe. Crutch length should be adjusted to allow for 2 to 3 finger breadths between crutch and axillary fold or armpit. Hand grips should be adjusted to allow for 20 to 30 degrees of elbow flexion, and the wrist should be held straight when adjusting the hand grip. It is not enough to properly fit the patient with crutches. The athletic trainer must provide appropriate instruction for ambulation. Walking gaits with crutches will vary depending upon the goal of the crutch use. A swing gait for non-weight bearing is used with the injured extremity held off the floor, and crutches provide support to swing the unaffected extremity through. Caution should be used to avoid placing pressure on the axilla and to instead use the hand grips to control crutch placement and movement. Light toe touching or partial weight bearing follows a similar process, as the injured leg and crutches are put forward together to allow for partial weight bearing. 4-point walking is a technique often used for gait training. It involves starting with the feet together and moving one crutch forward by the one step forward with the opposite foot. The process is repeated with the opposite crutch and foot. Patients may be more comfortable or may progress to using only one crutch or a cane. When using one crutch or a cane, use the following guidelines. The top of the cane should fit the level of the greater trochanter with the arm resting at the side. The elbows should be in slight flexion during cane ambulation. The crutch and/or cane should be used on the side opposite the affected extremity. This allows for the weight to be distributed away from the injured body part. Navigating stairs is sometimes a daunting task for patients using crutches. However, it can be made easier by remembering the simple phrase, good guys go up and bad guys go down. This means that when you are going upstairs, you should place the unaffected extremity on the up step and then follow with the affected extremity and then support the weight with the crutches. When going downstairs, you place the affected extremity and the crutches down together and lower your unaffected extremity to the next step. Patients should be instructed to proceed slowly and use the handrail for additional assistance if necessary. The ability to provide initial care and proper first aid is a foundational athletic training skill that can be learned early in the athletic training curriculum. In addition to CPR and advanced rescue techniques, athletic training students should be competent in wound recognition and care, treatment of acute inflammation, recognizing and treating shock, proper splinting techniques, and fitting of ambulatory aid devices. All first aid and initial care techniques are guided by the EAPs. Initial care is dictated by the ability to recognize and understand the underlying physiology of the inflammation and healing process. Understanding this process is the cornerstone to further study and treatment and rehabilitation of injuries and conditions.